Okay, and then forward, and it's just like, okay. So once again, thank you. Here are my disclosures, and as sort of a backdrop to this talk, I just wanted to point out some fundamental differences between private care perspectives and public health perspectives, because I think it's important to sort of keep these things sort of in the back of our minds when we go through this. So when we talk about a private care or primary care perspective, our focus is always on the patient individual well-being, and as a result, the financing of these services are pretty much based on patient benefit, and so there's always an incentive to maximize patient services to a certain extent. By contrast, the public health perspective focuses on treating the patient to prevent STI transmission to the community, and so the focus is really on the public health benefit, and financing is often also based on the public health benefit. And so there's an incentive to maximize services to those patients where prevention benefits are the largest. Now, this may all sound very kind of ho-hum and for us, very self-evident. However, there's, especially in the United States, there's an unfortunate misconception that public health is really health care for the poor. And so if you provide universal health insurance that will give everyone access to health care providers, you don't need public health. And so for STI and STD clinics, they really need to provide a safety net function until everyone has health insurance and can access the private system. A lot of people think this way. So what does that look like? So here's a woman. She's pretty high risk, and she said, "I need an STD check." And the provider, who's there on the lower right-hand side, he says, "Do you have health insurance?" And you know where this is going to end up, in the safety net. And it doesn't look very, very comforting to me, because I see there's major holes in this unraveling. So that's our safety net. Now, in 2014, in the United States, the Affordable Care Act was instituted. And if I see this picture, it brings a tear to my eye. It seems like 100 years ago that this person was in charge in the United States. Anyway, the Affordable Care Act, also known as Obamacare, basically involved mandatory insurance for everybody, very important component of it, expansion of Medicaid, which is a public health insurance, as well as the establishment of health insurance exchanges, and importantly, pre-existing conditions were no reason for exclusion of Obamacare, and youth under the age of 26 or under the age of 27 could be insured on their parents' plan. And so since the enactment of the Affordable Care Act, actually health insurance access has increased for over 20 million Americans, but still 10% of the population is uninsured. At the same time, the number of STD clinics has declined in the U.S. by about 10% per year. So this is kind of what you then would have expected, given what I was just saying, like, okay, the private insurance becomes available and STD clinics are no longer needed. Or are they? So this is the states that expanded Medicaid in blue, and what you see in orange, those are the states in the United States that did not expand Medicaid. Now, unfortunately, if you look at this map and you overlay it sort of with a map of gonorrhea incidents in the United States, you could see that the darkest blue states in the southeast actually are those that have not expanded Medicaid, which is really a pretty important problem because, those would really need the expansion the most, at least from an STI perspective. Now, this is just one slide from CDC that looks at the reporting source of different reportable STIs, and this is for chlamydia. And what you can see on the left-hand side is that about 30 to 40% or so are reported from primary care. Okay, so the primary care really plays an important role in STD control. And the second bar is our other health department clinics and so forth, and it's estimated for chlamydia at least that about maybe less than 10% of all chlamydia cases are actually coming from the STD clinic. Now, this is a graph that comes from the Netherlands, from the RIVM, the Public Health Institute here for 2017. And what you see here is that, like in the United States, so there's no big difference there, about 2/3 of all the STD consultations occur in primary care, and about 40% or so of chlamydia and gonorrhea, at least, and probably more of syphilis, are actually diagnosed in the STI clinics. So it's even more diagnosis than you would expect from the United States perspective. So, coming from Amsterdam and currently living in Denver, I've always been sort of intrigued about the differences between these different cities. So there's a small tale of two cities, and so left is Amsterdam. I was born here, I was raised here, went to medical school, and started my career in STIs in Amsterdam, and then I moved to Denver in 1986, and I've lived there for over 30 years. And I've included the altitude of these cities to make a major point about what is the biggest difference between Denver and Amsterdam. You know what it is? It's, you know, in Denver you could get high without getting stoned. But these are the two cities I love the most. Well, there's more to it. So the interesting thing is that the metropolitan area in Amsterdam is about the same as it is in Denver. Of course, the health insurance picture in Holland and Amsterdam is pretty different, where here you have pretty much universal access, and even though we have Medicaid expansion in Colorado, we still have a large proportion of folks that are uninsured, and particularly among minorities, and in our clinics, you know, the proportion of uninsured is even higher. Both cities actually have one major STD clinic. Here in Amsterdam, it's the GGD, GGD SOA-Poly, and that's where I started my career back in 1982. And the Denver Metro Health Clinic is the clinic where I've worked since 1986. The interesting thing, though, if you sort of look at the number of visits per year, it's 50,000 and growing in Amsterdam, and it's about 13,000, 15,000 is a little bit overestimated, but it's about 13,000 in Denver. And I have really sort of scratched my head on this many times. And I thought, you know, why is this? Why do we have such a huge discrepancy? And I think there's many reasons, you know, behind the difference between these numbers. And I'm not going to go into that because I don't have any time for that. But just the fact that you would have so many visits in a publicly funded STD clinic in Amsterdam where you have universal access, that means everybody's got what they call a house doctor, a huisarts. Okay, so everybody has a primary care provider, and they can go there to get chlamydia screening and gonorrhea screening and so forth, but they choose not to do that and actually instead go to the clinic. Now, similar things actually are happening in our clinic in Denver. So this is a study that was published in 2015 from our clinic, and it was basically looking at the effects of the Affordable Care Act at the Denver Metro Health Clinic. And what you can see is a steady growth, even in the time frame of just 1 year, that with the initiation and the implementation of the Affordable Care Act, that actually the number of people that got insured increased in our patient population. What's also interesting, though, is that if you would think that if people get health insurance, they would move away from the STD clinic to the primary care doctors, that's really not happening because the proportion of people that have insurance in our clinic is actually increasing. I would have actually expected that this would be staying the same or maybe even sort of decrease. So why is that? So we asked the question, you know, why do you come to this clinic? And we sort of here stratified by those that are insured versus those that are uninsured. And maybe not unexpectedly, confidentiality plays the major role. Almost 40% of the folks, whether they're insured or not insured, they say that confidentiality is the main reason why they continue to come to the STD clinic. And by the way, those folks here that say that they have insurance, about half of them actually choose not to use it because of confidentiality reasons. So they would rather pay the out-of-pocket copay rather than getting the bill sent to their home. Quick service is another important thing, and if you look at those that are insured, the fact that the clinic has specialized clinicians is actually important to them, as also a reason is that they were unable to be seen by their care providers. And of course, cost and location, cost and not knowing where else to go was more important among those that are uninsured. So looking at STI care models, so there's a private and a public, and I'm not sort of saying that one should pick one over the other. I think the ultimate conclusion is that these really need to work in tandem, because there are pros to the private approach because they have high coverage, particularly if like for example in Holland, where everybody has a primary care provider, and they can easily provide basic STI screening service like chlamydia, gonorrhea testing, maybe syphilis testing, HIV testing, and so forth. The cons are that most patients in a primary care setting are not at very high risk, and STIs are therefore not a priority to a primary care provider, and as a result they don't have a lot of expertise. If you look at the data in the US, where we have almost 30,000 cases of early syphilis, that means that an average primary care provider will see a case of early syphilis maybe once every 5 years. So that means there's not going to be a lot of experience there. The public health impact of our primary care setting, therefore, is more limited to generalized epidemics like chlamydia and maybe some of the viral STIs. By contrast, the public STD sort of clinical models, they serve high-risk population. They diagnose and treat large numbers of STIs. They have high levels of expertise. And on the other hand, you know, they have low coverage. There's not a lot of people coming there, and there's stigma associated with these clinics as well. I would argue that the public health impact for STD clinic is mostly in concentrated epidemics. And when I'm talking about concentrated epidemics, what I'm really talking about is HIV, syphilis, gonorrhea, lymphogranuloma venereum, hepatitis C, and most of these infections are overlapping epidemics among populations that STD clinics have good access to, like MSM, sex workers, injection drug users, and other high-risk populations. Another point to make is that in STD clinics, we disproportionately serve folks that are symptomatic rather than asymptomatic. So if you look at urethral gonorrhea, where 90% of the men are probably symptomatic, that if they come to a clinic, and these are data, by the way, from Melbourne, from the STD clinic in Melbourne, provided to me by Kit Furley, and so they did a study to look at the duration of symptoms when a person comes to the clinic. And for men with urethral gonorrhea, that's about 2 days. So if you intervene, 2 days into a symptomatic infection, you basically prevent a lot of ongoing transmission, whereas if you leave them untreated, they will have symptoms for a much longer period of time and will therefore be more likely to spread the infection. Now, talking about Melbourne, I thought I threw that in here as well. They have a metropolitan population that's larger, almost twice the size of Amsterdam or Denver, but they also have universal health insurance. And if you look at the clinic, likewise, they have huge amounts of people coming to the clinic, about 50,000 patients, maybe per capita a little bit less than in Amsterdam, but still showing that these STD clinics, these publicly funded clinics, they serve a very important need. So why do we need STD clinics? Why do we need publicly funded STD clinics? Well, again, they serve populations that are at highest need and therefore have a big public health impact. But we also have these clinics to do other things. We can use them for sentinel surveillance, to look at trends among high-risk populations. We do look at antimicrobial resistance, particularly for gonorrhea. So it's an important place to do surveillance. Then, of course, there's clinical expertise for diagnosis and treatment and consultation, as well as training of the workforce. And then there's an area of research where we work on public health projects, but also work with academia and increasingly with industry to further the whole field of STI research. Now, there are other models of STI care, and I want to briefly mention them because I'm already running out of time. In the U.S., particularly important are correctional facilities. A lot of people are incarcerated, and a lot of them are at very high risk for STIs. And I think we underutilize the correctional facilities as a place where we could do a lot better in screening for gonorrhea, chlamydia, syphilis, and other STIs. In the U.S., family planning and women's care clinics are obviously also very important because they serve young women that are at disproportionate risk for chlamydia and gonorrhea. School, college, and university clinics. We have the Indian Health Service. There's HIV testing and HIV care settings. So there's different other places where we actually provide STI care. And then we have the GLBTQ care centers, and I want to say a little bit more about that because I think they're emerging as sort of an alternative site of STD care. Initially, these gay, lesbian clinics were initiated to serve the specific health needs of this community, including STIs, but they got increasingly engaged in HIV care and prevention since the early 1980s, and now they're also a major provider of PrEP. And they increasingly deal with non-HIV STIs because of the increase in syphilis, gonorrhea, and other STIs among HIV-infected persons since the late 1990s, and increases in STIs among non-HIV-infected populations in the PrEP era. And so this is one of them. One of my favorite ones is Open Arms in Jackson, Mississippi. Leandro Mina is the person here in front who started this healthcare center in the United States. But we see more and more of these types of clinics opening up that have a specific focus on GLBTQ communities and are increasingly providing STI services. Now, this is a slide that you've seen many times before, and it really shows that that within the PrEP era we're seeing increases in STIs, and this is something that we really have to deal with. And this is a slide that I borrowed from Tom Quinn. It's sort of this frying pan into the fire sort of situation where you were dealing care with HIV prevention, but we're paying a price in terms of increases in STIs. I want to say a few things about cost and funding of STI care. So there's a number of ways that we fund care for STDs. In the private sphere, it would be out of pocket. There's different insurance kind of schemes. In public spheres, we have national health services like you have in the UK and Australia. Other governmental funding, so for example, the Amsterdam STI Clinic that we're talking about, with a budget of about $10 million, they get $9 million from the federal government and $1 million from the city. So that's their major sort of funding. In the U.S., it's a little bit different, where we have other types of insurance that I just talked about, and we're actually having to looking at diversification. So our STI clinics are really underfunded, and so what can be done about that? So these are sort of my thoughts about that, is that first of all, within the publicly funded STD clinics, we first have to determine our public health priorities. Very important, okay? We cannot be everything to everybody because we simply don't have the resources. We have to focus on the biggest fish that we can find, and that's HIV. Predominantly, we identify, diagnose, and refer a disproportionate number of new HIV cases, and of course syphilis and gonorrhea, and increasingly LGV, increasingly sexually transmitted hepatitis C, and so forth. We have to focus on high-risk populations, and we have to defer lower-risk populations to primary care. By the way, that is something that is done here in Amsterdam as well. How can we enhance our efficiency? Well, we can use the internet. We can use online resources to triage patients, to provide test results, to trace, diagnose, and treat partners, as we heard about earlier this morning. We can initiate express or fast-track visits. Electronic medical record can help us, and we can streamline our staffing models. Not every patient has to be seen by a doctor. What can also be done? We can increase revenue by offering family planning services, for example, and to provide HIV care and prevention, including PrEP, very importantly. And we can develop partnerships with academia, industry, as well as community alliances. Just last week, I did a quick study of how our clinic in Denver is currently funded, and we have a budget of about $4 million. And over time, we are now getting city and state funding for about a third of our budget, about $1.5 million. And we are actually generating clinic revenue by billing patients and their insurance systems, and that's now also good for almost a third of the overall revenue. And we get a significant amount of money from family planning. So we offer complete and integrated family planning service for which we get money from the state and from the federal government. And then we have a growing pot of research money, about $400,000 currently, and hopefully that is something that we can expand. So you could see that, at least in the U.S., it really serves us to diversify our funding because we can use these other fundings to serve our primary needs. Okay, I have one more view, and that is from New York, and you've heard about that earlier in this conference as well. They got a metro population of 8.5 million. They got Medicaid expansion, and they have actually 8 STD clinics with a census of about 80,000. Now, this is a graph or data that you've seen before, where you could see that folks that come, particularly MSM, that come to the STD clinics in New York, that a lot of them, particularly if you look at those that are diagnosed with anal, rectal, chlamydia, and gonorrhea, they actually have a very, very high risk to get HIV in the year after. So there was a big push in New York to end the HIV epidemic, and with the science behind them and the community support, there was a huge community sort of outrage about the function of the STD clinics, as well as the political will. They got significant amount of money to totally transform their public STD service in a much broader sexual health service and a shift to a sex-positive culture. So they expanded their scope to assure every patient with their HIV prevention needs, their contraceptive needs as well. And so no longer a revolving door, but now a gateway and a bridge to long-term sexual health service. So a real nice shift from this sort of safety net, like, last resort kind of clinic, into something that is much more positive and actually has much more sort of longevity. So here are my conclusions. STI control requires a very strong combination of both private and public health care response. So don't get me wrong, I'm the public guy, I come from an STD clinic, but I really see the importance of our private partners, and I think we both have very important and complementary roles to play in STD prevention. However, the funding of public STI care, particularly in the U.S., is in jeopardy, and in many other countries as well, and must be secured and expanded. So here's my last slide. You visit STD clinics, and you see the world. Here are my acknowledgements. Thank you very much.